morning, everyone. Welcome to the breakfast platform. Today we are very honored to have Dr. Nuryana. So we are both from Department of Medical Microbiology, and she has over 10 years experience, and she's our in-house clinical microbiologist as well. So without further ado, I pass the time to Dr. Nuryana. So her title is basically on leptospirosis. So I'll wait for her to tell us more about the challenges facing leptospirosis diagnosis.
Okay,
right.
Thank you, Prof. Chan.
Okay, it's good.
Okay. All right. Good morning, everyone. Okay, so today I'm going to talk about the challenges that we are facing to diagnose leptospirosis in our diagnostic lab. Okay, so basically leptospirosis is a globally distributed zoonotic disease. Annually, it's about 1 million cases worldwide, okay, with 58,000 deaths annually. And this leptospirosis is highly prevalent in Asia-Pacific region, and specifically in Southeast Asia and Oceania, and including Malaysia, Thailand, and Indonesia. It is endemic in Malaysia. The first case reported, leptospirosis case reported in 1925. Since then, there is a case, but it's always underreported and not recognized by the clinicians, and it is underdocumented. So it's become a notifiable disease in 2010. Okay, this is the global distribution of the outbreak of leptospirosis. As you can see, we are here. So there's an outbreak here in Southeast Asia, and also it's not much different actually, even though they say that it is more of tropical disease, but you can see they also occur in temperate region as well. So okay. So for incident and mortality in Malaysia, you can see that this is 2015's statistic. The highest in that year is Malacca, okay, and then the rest will be Selangor, Kuala Lumpur, and the rest will be Perak, Pahang, Terengganu, Kelantan, and Sabah and Sarawak. So it's about the same. So you can see the incident rate in Malacca in that year is about 68. Okay, so basically, most likely in that year there is an outbreak in Malacca. That's why the number is quite high. But average, you can see all the states that contributes to the cases. Selangor, Perak, and Kuala Lumpur, and maybe because this is where there's the majority of the populations there. And then the mortality rates is about 1.5%, less than 1%, and there's one it's about 1.9%. So overall, it's about 1.5%. Okay. So from the same paper, you can see the most common age group for this leptospirosis is about the age 19 years old. So maybe this is due to their activities. They are very active at that age, and also they are involved a lot in water activities or recreational activities. And students actually in that year is the highest risk group, okay, followed by plantation workers. And at that year, the fertility rate is about 1.5%, and the incidence rate is about 29% per 100,000 population. So actually, but if you look in another statistic in another year, the risk group will be different. I think it depends on the outbreak of that year. If the outbreaks happen in the plantation areas, so the plantation workers will be the highest risk groups, okay, the highest group that get the infection. Okay, so just a bit on the morphology of Leptospira. It is spirochetes, okay, and this is a corkscrew shape, and it differs from other spirochete through by the end of the organism. They have hooks, okay, and they are thin and helical in shape. And under the electron microscope, it have a typical double membrane structure. Okay, and they are in which the cytoplasmic membrane and glycan cell and cell wall are closely related and overlaid by outer membrane. And within the membrane, the lipopolysaccharides constitute the main antigen. So this is important, the LPS, because this is where actually we use to classify the leptospira. So the classification of leptospira is based on the expression of the surface exposed epitopes in the mosaic of the LPS. Okay. So this is just another diagram to illustrate where the LPS and this is the shape of the spiral sheets. Okay, so basically for classification, before 1989, leptospira divided into two species. Leptospira interrogans, which is considered as pathogenic, and Leptospira pexa, which is considered as non-pathogenic or free living or saprophytic. But currently, there's a two separate system of classification I use. One, we use a traditional phenotypic classification based on serotyping. The second one, which is currently in trend, we are using the genotypic classification based on DNA homology. So for this serophenotypic classification, within each species, we organize them to serovars, and the serovars then we organize into the serogroup based on shared antigen. So basically, Leptospira interrogans contain about at least 218 serovars that organize into 23 serogroups. And for Leptospira pexa is contain at least 60 serovars organized into 28 serogroups. So, okay. Basically, genotypic classification system is taxonomically correct, but because of the lack of simple molecular identification methods, many diagnostic labs retain the serology classification of Leptospira. And we also, as a clinical microbiologists, as clinicians, we are also familiar with the old or the conventional classification system, which is a serology classification system. So most of the time we refer to serology classification a system of Leptospiras. So this is just to show the saprophytic. This is actually how they differentiate whether it is a saprophytic, pathogenic, and even intermediate by the way they grow in a certain temperature. Okay, so example like saprophytics, Leptospira, they prefer to live between 1 to and 35 degrees, and this is non-pathogenic. Okay, the intermediate one, they can live either between 1 and 37, and they can live as saprophyte as well as pathogens. Okay, there's two in there, the Leptospira inodia and parva. Okay, so the pathogenic one, they live between 20 degrees Celsius and 37 degrees Celsius, and it causes diseases in rodents and humans. So this is again the Leptospira classification. You can see the left side is a serology based. Okay, like I mentioned before, is pathogenic and pathogenic, and they have a serovar that under interrogants, they have 250 serovars, and black fexa, they have 65 serovars. And on the right side, you can see we're using genotyping by DNA hybridization, and also 16S RNA base. Okay, so we divide them into pathogenic, intermediate, and saprophytic. Okay, and there's about quite a number of genus we able serovar that we'll be able to identify using this the genotyping. So this is just to show actually the serovar that circulating in Malaysia. Actually, there's a few papers mentioned about they did a seroprevalence study. So you can see this is from Sabah, I think. Yeah, this is from Sabah, and you can see there's so many serovar circulating in our countries, and some of this is our local serovar, such as Sarawak, we have Terengganu, okay, and we have other maybe from Javanica from maybe from Indonesia, and also we have the WHO strain or international strains, okay. So there's quite numbers of cerebral circulating actually. In Malaysia, the most infected Leptospira species is Leptospira interrogans, Leptospira kirchneri, and Leptospira golfi. Okay, so the human infection transmitted via direct contact, either contaminated blood or infected tissue from animal reservoirs, or indirectly from contaminated water and soil. Okay, so for the contaminated water, bear in mind that Leptospira can survive for about 6 weeks in the stagnant water. So they are quite viable in water, in environment. So that's why it is important to know to actually to warning the public. Okay, so for animal reservoir, it can be either wild or domestic animals. Rodent is the most common animal reservoir. It can also have what you call cows also is another animal reservoir which is significant, give a significant contributions to infection in our country. This is happen in plantations area where actually the farm workers they are working in the area, and you know when they're dealing with palm fruits, normally they have a very tiny thorn in the on the palm fruit. Yeah? So and in the area of the plantation it's not easy to get a water. So sometimes there is a stagnant, a small area with the of the small stagnant water. They wash their hand there, and at the same time there is a cows around that area that urinate and contaminate the water. So and normally the lesion or the cut on their hand is go unnoticed because it's too small. And remember, Leptospira also is very thin and very motile organism. So that's why plantation workers is one of the main risk factors that to get this infection. Okay. So the clinical features, that's one of the challenges about this Leptospira, because its symptom may mimic a number of other unrelated infection such as dengue, typhus, influenza, meningitis, and other viral illness. And the spectrum of disease is extremely wide, ranging from subclinical infection to a severe syndrome of multi-organ infection with high mortality. So there's another issue about this Leptospira where they always co-infect. Okay, they always co-infect. There is a list of diseases that actually co-infect with Leptospira. Dengue is often associated together with Leptospira, and because this has been reported in various countries, this is including Puerto Rico. Okay, so that's the issue with dengue, because both actually come up with acute febrile illness. And then both actually have a very severe complication, because Leptospira can develop real disease, disease over syndrome, which is can lead to a severe diseases application. And dengue also can develop hemorrhagic dengue fever, which actually both actually can lead to high mortality. So this is the Netro et al. Reported case of Leptospira and Zika pathogens, and they are co-infect without any obvious clinical feature. In that case, the patient did not have any distinct rashes, but Zika nucleosis vulnerability increased. And the theory behind that, the author said that the most likely the symptom of Zika infection may be masked by the more virulent symptom in leptospirosis. Okay. And the leptospirosis and malaria also, they are a multi-infection, especially prevalence in Thailand and Myanmar, and I think Indonesia as well, in Sabah. And also here, the hantavirus hemorrhagic fever co-infect as well with Leptospira. And this is the one particular case report to say that the Croatian soldiers suffering from leptospirosis and hantavirus hemorrhagic fever with renal syndrome. From a background, the soldiers live in a rodent-infested area. They Therefore, this is increasing likelihood of contracting the co-infection. And another common co-infection is leptospirosis with scrub typhus, and this is especially prevalent among agriculture workers. Okay, so this is now we go to the lab test of leptospira. Basically, Leptospira is a bacteria. So, you know, the ordinary bacteria will be able to visualize under light microscope, but not Leptospira. They can only be observed by a dark microscopy as a thin, bright, actively motile rods, rapidly spinning and jerking motility. So, the sensitivity of dark field microscopy is about 10 to the power of 7 leptospiras per liter and about 10 leptospiras per mil for one cell field to be visible by dark field microscopy. And if you look, the positivity is decreased from 100% to 90% with increase in the duration of infection greater than 1 week. Okay, so as you know, the leptospira is abundant in blood in the first week of infection. Okay, but again, the direct examination of blood and urine has both low sensitivity and specificity. And for direct examination of blood is always a misinterpretation of fibrin or protein traits. Therefore, the direct observation is not recommended as a routine procedure. So this is one of the changes. We cannot use direct observation on leptospira. For culture, again, this is difficult and laborious as it is can up to 3 months for colonies to appear. Okay, so the normal range or the normal duration for the colonies to appear is about 13 weeks. Okay, so which is not suitable for to diagnose acute infection, but it's good to use for retrospective diagnosis. Okay, and the sample selection is either tissue or body fluid, and we need to know the stage of infection because in the acute phase, about 10 days, leptospira can often be cultured from blood and CSF. But when the specific response, I mean, after more than 10 days, the detected leptospira will disappear from the blood. So during the second phase, then the bacteria start to be excreted through the urine. Okay, so this is after the second week, after the 10 days, urine is more important specimen. Okay, so even there is a study to say that CSF is not good actually to use to do the culture. Okay, there's only a few leptospiras present in CSF. So this is the photo to show that the growth from blood in a semi-solid media. So as you can see, the leptospira on the left side, the right side is -1. On the left side, you can see there's a forming a subsurface colonies. Okay, this is after how many weeks, and then this is the image from the dark field microscopy. Okay, so what happened from these colonies that occur in the semi-solid? Then we have to visualize either using the dark field or we have to identify the seroma by microaggregation test. Okay. So this is the sample collection for culture. It will be good to take the culture if you want to do the culture before the administration of antibiotics. Okay, we mentioned before, blood and CSF should be cultured in the first 10 days and urine for the second week of the illness. And the sample should be stored and transported at ambient temperatures. And survival of leptospira in human urine is limited. So if you want to use urine to do the culture, you need to process it as soon as possible. Okay. And the culture is incubated in a dark about 28 to 30 degrees Celsius and examined weekly by the field microscopy for up to 30 weeks prior to be discarded. So this is the average time that need for the leptospira to grow. Okay, the 30 weeks, but sometimes can up to a few months. Okay, this is the most used medium is EMGH medium. Okay, so this is the one that we use in the lab as well. For antigen detection, the test has been developed, but so far there's none of them is sensitive enough to be routinely used. So I'm not going to touch on the antigen detection test. Okay, so the antibody detection is the mainstay. This is the main serological test for Leptospira. So currently that we are using in the lab is the MAT or micro agglutination test. Was first described in 1918 by Martin and Pede. Okay, so basically the principles of this test, we use the live antigens that representing different serogroups, and they're supposed to react with a serum samples, and the agglutination is examined under the dark field microscopy. So we are using the panels of live leptospirosis as belonging to different serobus, and the viable live antigen must be maintained in the lab. So as a minimum, the panel should include all locally circulating serobus, and if the serobus are known or subject to change, the panel should include serobus representing all serogroups. Okay, because if the incomplete panel, it should be responsible for false negative. Okay, so this is the dilemma for us in diagnostic lab, because when we talk about the full panel, it's about 20 or 20 plus serobus. Okay, and here we're using only one serobus, which is non-pathogenic. Okay, so to maintain actually the viable antigen or viable leptospira is so laborious and also time consuming. Why? Because every week we have to do the subculture, okay, and then we have to check whether the organism is still alive and still viable, and then we have to make sure in this meeting if we have to maintain 20 serova, and the antigen is quite weak, then we need to inject the animals, okay, to get a new strains or new serovas. So basically, we need a very complete lab to be able to do this, to do all what the minimum requirement of this MAT. So we need to do the whole panel of antigen. So because if not, it will give a false negative result. But so far, from my experience, we had a visit to IMR before, and so far our PETOC, our non-pathogenic, cross react with other seroa, which is I think is a good for us. That means we know that we will not miss other serovas that at the moment are circulating in our countries. But having said that, we are unable to actually identify the serova. We just know it is positive, but we are unable to say, oh, this is belong to a certain serovas. Okay. MAT normally positive from day 10 to 12 after the onset of illness. That means after the antibody develop. So, and sometimes will be later if specific antibodies have been prescribed. Okay, so the MAT during the first week of disease, the sensitivity is only 41% and increase to 82% during the second to fourth week. And after the 4 weeks, which is it will be like almost 96%. But of course, the most important for the clinician, they want to know the diagnosis during the first week and at least during the second week. Okay. So this is just to show you the immune response in Leptospira and what specimen that important. As you all know, for PCR or culture, blood is important during the first week. It is a very important specimen, and then CSF is like not so many leptospirosis in the CSF, but it is acceptable specimen. And of course, after week 1, urine is the most important. This is for PCR or culture. For antibody, you can see this antibody only developed after week 2. Okay, so even it will be low conversion if we give early antibiotic treatment to the patient. Okay, so and then we might miss all this antibody detection around this area, the early week 1. So the cutoff value of single serums or single sera depends from the seroprevalence. Okay, so for CDC, the probable case is defined if the titer if more than 200, and it is associated with clinical compatible illness. So different countries have different cut value on the single serum. Like Thailand, Taiwan, the antibody titer for to say that is they have the infection is about more or equal to 100. In the Thailand, they use about the single titer of more equal to 400. And in Malaysia, if you refer back to the guideline from KTM, the titers is about 1 in 400, so equal or more to 400. And this is one, the leptospirosis burden epidemiology reference group. Consider single met is more than 1 to 400, and for non-endemic, more than 1 in 100. Okay, then this is consistent with leptospirosis. Okay, I think I need to speed up. Okay, although titer is appropriate in population with exposure to leptospirosis is uncommon, but if exposure is frequent, the tropical country will need a higher cut of titer. So this is what I said before. Okay, there's another thing about actually the best to detect the leptospirosis is by we need a couple. That means we need acute convalescent serum. Okay, so there is, you look at the rise of the titer. So this is the confirmation for that. Okay, but in case of previous infection with different serogroup, interpretation is complicated by the amnestic response. It means the antibody titer is directed against a previous infecting seroviral. So this is another phenomenon what we call as an amnestic response. So basically, if you had a previous infection with a previous seroviral, so the antibody titers were directed against a previous infected seroviral. So the result, if you are looking for the seroviral, so it will be positive with another the previous seroviral, not the current seroviral. And the MAT detect both plus IgM and also IgG. So because of that, it cannot differentiate between current, recent, and past infection. And you may be able to identify the presumptive serogroup under the best condition. The seroviral, because interpretation is complicated by the high degree of cross reaction that can occur between different serogroups, okay, especially in acute phase samples. MAT also is complex to control and perform because we cannot standardize the test because of the live leptospirosis are used as antigen. Antibody detection and another method use ELISA. Hi.
Dr. Nuryana, maybe we can wrap up 2 more slides, yeah.
Okay, all right. So basically, the antibody detection using ELISA, it is broadly reactive genus-specific antigen. It is not suitable for identification of the causative seroviral. And most of the commercial ELISA, they're using non-pathogenic leptospira reflex petox strains. And the good thing is ELISA is positive for T6 to 8 earlier than MAT. Okay. But however, the positive ELISA should be confirmed by MAT. All right, since we are just a few minutes. Okay, for rapid screening tests, there's a few actually available rapid screening tests. And it is confident again, they are detecting IgM. So there's a few important. The good things about this test, actually the rapid screening test, it can be performed by individual without specific technical training. And then but however, the inter-observer variability in reading and interpretation of the endpoints may provide inconsistent results. Okay. And because of the low sensitivities, it is not suitable to use in the acute initial management of the acute leptospirosis. Because this is the reason why, because most of the rapid screening is with IgM, which is unable to detect the IgM in the early phase of the infection. So the molecular diagnosis is actually is the moment is developing, okay, because more and more people move towards this molecular diagnosis. And the good thing is because PCR able to detect DNA in blood in the first 5 to 10 days and up to the 15 days, okay. So and PCR allow detection of the spira in culture negative blood and the patient has received an effective intramuscular drug but have not cleared the non-viable organism. Okay, so this is all the molecular diagnosis. I think it's quite a lot. Okay, just come to the conclusions. Okay, due to overlapping signs and symptoms of leptospira with other infection and co-infection that further complicates the clinical diagnosis, we need a reliable lab test, okay? And we need the need of user-friendly and cost-effective diagnostic test for this is important, okay? And due to what range of animal reservoirs and change in circulating serovirus, surveillance of seroprevalence is a need for adequate control of the infection. And last point, that the coordinated cooperation between institutions is important, as almost impossible for individual lab to run a laborious and time-consuming leptospirosis test. I think that's all my presentation for today. Thank you everyone for listening. So this is my references. Okay.
Okay, thank you, Nuryana. So that's one question from Prof. Tunku Sara. So she gave a comment. So she said it would be nice, it's a great talk to combine, if it would be good to combine with typical patient as a case presentation. So I think that's a pointer for us. And her question is actually, is there any recommended prophylaxis for plantation workers or someone that is that enjoy water sports in the rural area?
Hold on. So I can't hear
so
your.
She's asking profit. Can you hear me? Yeah, the question.
Sorry, I can't hear you.
The question is actually in the Q&A, so you can see the question. And Prof. Tunku Sara's question is, what is the recommended prophylaxis for plantation workers or someone that enjoy water sports in rural area?
I think I'm not in the view of answering the suitable, because we are more on the lab-based person actually about the antibiotics. Okay, so maybe the ID people can help to answer the antibiotics decision for the prophylaxis. And but normally they use a doxycycline, if I'm not mistaken, for the prophylaxis of the leptospirosis. Okay.
Okay, so maybe I have one last question before we pass the time to the next speaker. So what we understand a lot of diagnostic challenges, but what are the new diagnostics and possible new things, new diagnostic tools that we can actually recommend or actually implemented in UMMC for leptospirosis, or actually any acute, any pyrexia, PUO, pyrexia of unknown origin?
Like I mentioned before, most of the current available or commercially available kit is to detect the antibody. Okay, so again, so far from my experience, we still it is molecular diagnosis is the best, I think, to diagnose, as we'll be able to detect the antigen in early infection. So far, I think we have to go or to validate our commercially available PCR tests, so that you can use that for acute diagnosis of diagnosis of leptospira. Okay.
Okay, so we look forward for our PCR for UMMC.
Yeah.
Thank you, Dr. Nuryana. So I'm happy to pass the time to Prof. Gan. Thank you, everyone.